Good morning, ladies and gentlemen. It's a great pleasure being invited to your arthroscopy meeting in Egypt. The title of my first lecture this morning is Management of Persistent Pain After Hip Arthroscopy and Revision Hip Surgery. Looking at the results of hip arthroscopy, we realize that the results are good but not perfect. So, for example, the revision rate has been reported between 2 and 10%. Complications of hip arthroscopies are not very frequent but need to be considered, at least with the less experienced hip arthroscopist. We try to define the different phases for the post-operative clinical course after hip preservation surgery: the early phase within the first couple weeks, the healing phase within the first 3 months after surgery, and the remodeling phase at month 4, 5, and 6 after hip preservation surgery. Looking at the early phase, this phase within the first couple weeks after hip surgery is mostly influenced by direct operative soft tissue trauma, potential infection, and other complications. Performing hip arthroscopies, we always introducing and exchanging instruments multiple times, so irritation of the muscle and the capsule needs to be considered. Skin and soft tissue trauma can be a problem, so we recommend to position the patient always by yourself in order to avoid such complications. Prophylaxis within the first couple weeks, we always start with a CPM very early in order to avoid adhesions. We give the patient low molecular weight heparin in order to avoid deep vein thrombosis, and we always give the patient anti-inflammatory medications for the first couple weeks after surgery in order to avoid heterotopic bone formation. The second phase of the post-operative clinical course is the healing phase. This phase is usually influenced by the amount of operative treatment, bone resection, cartilage healing, labral repair, and other procedures you perform. So you do a lot of things by arthroscopy. For example, you do a lot of bone resection. For example, when you do a cam resection, labral refixation, rim trimming, abrasion, microfracture, cartilage treatment, all those procedures are important when you see the patient post-operative, and all those procedures may delay the rehabilitation time. Looking at the third phase of the post-operative clinical course, the remodeling phase, from our experience, this phase is mostly influenced by the cartilage status, the condition of the joint, and individual factors from both from the patient and from us, the surgeons. The cartilage status and the condition of the joint at the time of surgery is probably the most important factor. So you as the surgeon need to evaluate the preoperative imaging very carefully in order to discuss the joint condition and to discuss with the patient if you are able to meet the patient expectations. When you look at this imaging, those radiographs, you would say this hip does not look too bad. The joint space is still congruent and wide. However, when you look at the MRI, you see that the posteromedial joint space is already reduced. This joint is already incongruent, so probably this joint is not good enough anymore to perform joint preservation surgery. Wrong diagnosis, wrong therapy, this is another important reason. The knowledge about the hip joint, the understanding of the hip joint, we are still, I would say, far behind the understanding of the knee joint. So, for example, FAI is a very trendy diagnosis, and at the moment definitely overdiagnosed. There are other diagnoses such as dysplasia, etc., which need to be considered when you assess the hip joint. So when you, for example, perform hip arthroscopies, is always crucial to check the location and patterns of cartilage damage. If you see such a cartilage delamination at the anterolateral rim, this is a typical sign of CAM, femoroacetabular impingement. You always need to be open when you assess hip joints. For example, this patient here was suffering from psoas tendon impingement at the femoral head. So as I mentioned before, we are not as far as with understanding of other joints such as in the knee and shoulder. So you always need to be open about detecting new pathologies. Coming to the last topic of my lecture, revision surgery. When do we schedule those revisions? Usually we like to wait at least 3 months, at least if there's not a clear complication from the operation, and we like to confirm the hip as the source of pain by 1 or 2 intra-articular injections. How do we do it? If there's a clear intra-articular problem, usually we prefer to solve those problems again arthroscopically. If there's a more general problem such as dysplasia or other types of maltorsion, malversion, diffuse synovial disease such as in PVNS, we prefer open surgery. Adhesions are not so rare. They can be typically found at the space between the femoral neck and the articular capsule, and second at the perilabral sulcus between the labrum and the capsule, and usually those adhesions can be beneficially solved by arthroscopy. A common problem after open or arthroscopic treatment of FAI is over-resection or incomplete cam resection. This is a case of incomplete cam resection, and that case can be usually solved by arthroscopic revision. If, however, you have such a case with a massive over-resection, as presented here by Martin Beck from Switzerland, revision of such a case is much more demanding, and this requires complex open surgery. This is another example for an open revision. This female patient was scoped elsewhere with the labral removal. However, you see that this socket is residually dysplastic. We decided to scope her first, confirmed that the labrum is missing, that there's cartilage damage at the anterolateral rim, and the hip also shows signs of instability. We did a cam resection arthroscopically, but then finally we decided to do a staged periacetabular osteotomy to treat both acetabular dysplasia and instability. Take-home message from this lecture: our recommendation: do not revise too early. Consider longer rehabilitation, especially when you do more in the joint. It's recommended that you confirm the hip as the source of persistent pain by a local anesthetic injection test. If there's intra-articular pathology, we usually use arthroscopy for revision. If there are extra-articular problems such as persistent DDH, etc., we use open surgery, and sometimes even the combination of both. Thank you so much.